Okay. Sorry about that. Felt like it went by so quick, that other meeting. I felt like I didn't have a chance to talk about anything. So anyway, I just wanted to do this other one here just to make sure I could finish up with some of the things I was talking about and see if you guys have questions about anything. Everyone with me still?
Yes.
Okay, cool. Thanks. Glad someone said something. Okay. Um, I set this to start at 9:30, but I'm just going to start talking a second here. So again, we're in that PowerPoint about these different types of tubes. We're talking about NG tubes and PEG tubes. So we talked about a lot of the stuff in here. I'm just going to go over a couple other things as we're waiting for some other people to arrive. So some indications for why you might need tube feed. So there's a slide on that, and it lists a bunch of different things. So, maybe I was really debilitated. I had some type of car accident. I've been in the hospital for a long period of time. I haven't been able to eat because of some injury that I had. So they have to give me nutrition somehow. So they're going to give me tube feed. Other things that you might consider here. Um, so maybe someone is someone that has chronic alcoholism or anorexia or something like that. Someone along those lines, they would need to get nutrition as well. So you would put them on tube feed. If they had maxillofacial surgery, you had some kind of surgery on your face where you weren't able to eat the normal way, maybe this would be something you would do in the meantime. So those are kind of a couple of indications for why. So there is a slide on here about dumping syndrome, and this is kind of an important concept that I want you to make sure you understand. So this is probably one of the most important things in this PowerPoint. And I do want to call your attention to this in your ATI book. I don't have the exact page number on me because I don't have my book in front of me. But there is stuff about this in your ATI Med-Surg book in those GI chapters. So make sure you look at that. So with dumping syndrome, this can happen to people who are on tube feed. So on this slide, it talks about when a concentrated solution of high osmolality enters the intestines in quickly in large amounts. So typically, if our GI system is working like it should and we don't have any of those other issues going on, then as things move through, they're going to move through kind of slower. And so as things move from your small intestine to your large intestine, it's not going to be really fast. And you're going to be able to tolerate that okay, and you're not going to have problems. But for this situation, now you have a solution that we're giving this person with lots of stuff in it. So when I say high osmolality, that means the things that are in it, there's a lot of it, a lot of particles of different types of things. So the problem is that it moves through too quickly to your large intestine. So this happens with a bunch of water. So water moves rapidly into your intestinal lumen from the fluid surrounding the organs into the vascular compartment. So as a result of this happening, now you're going to have these symptoms. So the patient's going to feel really full. They're going to have nausea, cramping, dizziness. They're going to be sweating, and they're going to have osmotic diarrhea. So this is called dumping syndrome. So this can lead to dehydration, low blood pressure, and tachycardia. So it can be a big deal. So again, this is just happening because food and fluid together move too fast from the stomach to the small intestine. So to prevent this from happening then, you would want to give formula at room temperature. You don't want it to be like too cold or too hot. And then you would increase the feeding rate gradually. So you first would start it slowly via a continuous drip. So, on one of those pumps. So maybe I might start it at 10 milliliters an hour or something like that. I'm not going to start it right at my goal rate. So I start it slow, and then as I see that they're tolerating it okay, then I'm going to slowly get it up to my goal rate. So usually when you have an order for tube feed on a pump, the physician will order it like that. They'll say, okay, I want it to be at a goal rate of 40 milliliters an hour. So you would start it slow, and then over the next hour, you would see how they do, and then you would move it up if they tolerated it until you got up to that goal rate. You also want to keep the patient in a semi-Fowler's position for 1 hour after eating. So this means they can't be laying flat. They have to be sitting up. Now, I do want to say this. There are a couple of different ways that you can get dumping syndrome. This particular way we just talked about is because of tube feed. But you can get dumping syndrome after you have like a gastrointestinal type of a surgery, like say you had a gastrectomy or something where they actually remove a portion of your stomach or all of your stomach. You can have this. So there's a couple of differences, but there's some things that are similar. So you need to make sure you know the difference between the two and then why it happens and what you can do to prevent it. Make sense? Okay, I see a thumbs up from Ashley. Thank you. Okay, we'll keep going here. All right, so again, you can administer tube feeds in a couple of different ways. I think we're all used to like how you would do it, as a bolus feed. A bolus feed means that maybe you have like a can of tube feed and maybe your order says, hey, give, a certain amount of this 4 times a day. And so then, maybe you would schedule it for 612, 612, and you would go in there and you would, pour it down the tube with your big syringe that you have, and then like just let it go in by gravity. So has any of you seen people give a tube feed through a tube where they didn't do it by bolus and they just like shoved it in with the syringe? Yeah, so sometimes people will do that, and it's not necessarily the best way because, again, we just talked about this dumping syndrome. If you're pushing things in too quickly, people may not tolerate it very well. So the best way to do it would be through, just doing it by gravity or having it on a pump. All right, someone needs to mute themselves. Okay, maybe I fixed it. All right, let's see here. Okay, so then the next slide talks about assessment of the patients receiving tube feeds. So if you have a patient that you're taking care of with this, every day when you go in there, you should be looking at certain things. So every time you see this person, you always want to check for tube placement. And so this is really important. You want to check by 2 different ways. So I know all of you have probably seen someone do the air bubble with the syringe, that way. That's kind of an old way that everyone used to do, and I was always taught that way when I was in school. But in your book, it says that's not really an accurate thing to do, so I would never do that anymore. So what you should do now is, after you get it put in, if it's a new one that you just put in, of course you would get a chest x-ray, right? But every time you check it after that, you wouldn't always get a chest x-ray. That doesn't make sense. So what you would do is you want to, get a little bit of that GI aspirate out and test the pH of that. So that would be a good way. Another thing that you could do is when you first put it in, there's numbers on that tube that you want to indicate where that number is, right by the nose. So if you can do that, that's going to, if you have that charted, then everyone behind you is going to be like, oh, okay, the tube was at 30. So then when I come in, I know that it should be there. And if it's not, that means it's moved. And so that's not good. Can you guys think of anything else you could do to check tube placement? Yes, Brandon, you could withdraw stomach contents, but that's kind of what we were just talking about with, check at the pH. You also, though, could just look at what the stomach contents look like, because generally, like say you get, white frothy stuff and that's all you see, then that probably means you're not in the right place. Because what should stomach contents look like?
Brown?
Yeah, they could be brown. They could be like a greenish or a yellowish color. Yeah. So you're kind of going to know if you're in the right spot just by how that looks. So that's another way you can kind of check. But anyway, for testing purposes, always check 2 different ways with tube placement. Okay, other things that you're going to look at with this patient every day. So you look at their position. So are they sitting, upright in the bed, or are they flat? Because what happens if they're flat? You're going to be worried about them aspirating, right? So you always want them to be head of the bed up. You're going to check what kind of tube feed they have. So if they are on a pump, if it's on like an IV type pump, then it's going to be set a certain way, and the bag should have the name of the tube feed on it and like how fast it's going. So you're going to note those things. How would you know if they're tolerating their tube feed? Anyone have a thought? Okay, so certain things that you're going to see if they don't tolerate it would be lots of GI things. So like they could have nausea, vomiting, they could have, abdominal distension, they could have diarrhea really bad. Those types of things would indicate that they're not tolerating it. And Brandon's right, he said in the chat here something about if you withdraw too much with the stomach contents. So when we check for placement, we always also do a residual, right? So when we draw back residual contents out of the stomach, we don't want to see a ton of contents in there, right? Because that's saying that things aren't moving through quick enough and they're not going to tolerate it, basically. So usually you'll have an order from your physician about residuals. So when you check a residual, if you have a certain amount, they're going to want you to call them and hold the next feeding. So you can go by that. And then if you don't feel comfortable with the amount that you drew back and your order says something else, always call the physician and just talk to them about it, because they'll be able to kind of work with you with that. Okay, other things on the slide, it talks about signs of dehydration. Why do you think you would see signs of dehydration with someone that's getting tube feed?
They're not getting enough water with it.
Yeah, that's a good point, Brandy. That's very true. Sometimes people don't get enough water with it. If you've ever looked at the orders for tube feed, usually they will have a certain amount that you're supposed to give them, like, we were just talking about the bolus feeds, that maybe they get it 4 times a day, 1 can 4 times a day or something. Well, if you think about like a normal person, like how much they're supposed to eat and drink, these cans aren't that much. They're maybe 240 milliliters. So if you only get 4 of those, you're really like not getting enough fluid, right? So typically the doctor will order a certain amount of fluid to be given in between giving these tube feeds so that they can stay hydrated. So that's very important to look at that. So what kinds of things would you see if they were dehydrated? Concentrated urine, sure, that's a good one. They may be a little bit pale, sure.
Skin Is it turgor?
Yeah, skin turgor might be bad. Cracked, dry lips, someone said, yeah. What would be some things you might see with their labs? Yeah, so their BUN and creatinine might be elevated. So that's showing that their kidneys aren't working as well. Do you think that maybe you would see something different with your sodium?
Would it be lower?
It could be, yeah.
Can it be high and low in this case?
Yeah, it could be. You're correct. So you always want to make sure you check those labs as well, other than just looking at them physically, because that's going to give you a better picture about what's going on. So if you did see any of those things, that would be a reason for you to call the physician to say, look, maybe they're not getting enough water. Do you want to increase the amount that we give them? Okay, so some other things in here that I want to mention. So we always want to keep a really good eye on their intake and output. So we want to see how much we've given them and then how much they're actually putting out. Why would someone maybe have an elevated blood glucose level?
It's a lot of sugar in those tube feeds.
So the tube feed that they're getting may be causing it, you know? So maybe they don't normally take anything for diabetes, and maybe they're not diabetic, but they're having a high blood glucose. So that's something that we always need to watch as well, because maybe we need to check the type of formula that we're giving them and change that. So people could also have, you know, a change in their, like they could have swelling, they could have weight gain, they could have edema. So you always need to look at all of those things to make sure that they're doing okay. So as you're looking at them every day, those are the things that we really need to keep an eye on. We want to check that residual volume before each feeding, or if they're getting a continuous feed on a pump, we're going to do it every 4 hours. And then you always want to return that aspirate to the.
Can't hear you.
Hear you. This is Silk. We can't hear you.
How about now? Okay.
Yes.
I must have hit something accidentally on my mic. Sorry about that. Okay, so the last slide I just want to mention real quick before we get off here. This talks about gastrostomy and jejunostomy. So a gastrostomy would just be like a peg tube. So this would be, you know, say you have someone who had to get an NG tube for a little while and you keep working with them, but they're just not quite able to take in by mouth yet. So after 4 weeks with an NG tube, that's the cutoff point for having one. You can't keep it in for longer than 4 weeks. So you would have to take it out and they would probably end up with a peg tube instead. The peg tube you can have in way longer and it's not going to cause problems. So if you had a gastrostomy tube or a peg tube, they just do this procedure where they cut an opening into your stomach and they put the tube in that way. It's really kind of a short procedure. It's not too big of a deal. This is preferred over an NG tube to deliver enteral nutrition or tube feeds like we were just talking about for longer than 4 weeks. It's also preferred over NG feedings in a patient who is comatose because the gastroesophageal sphincter remains intact and it makes regurgitation and aspiration less likely. So that's why this would be, the preferred thing. There are going to be times where you see someone who doesn't have a working gut at the time. So if that's the case, then they would have to have a jejunostomy. And a jejunostomy would be placed in surgery, and it is something that they put right into the jejunum, so it bypasses the stomach and goes right into your intestines. So this would be where you could still give food, fluids, and medications, and it's only because that gastric route isn't working at the time. So certain surgeries that people have, sometimes they will come out of surgery with a jejunostomy tube. So you always have to make sure that when you get someone from surgery, that they're very clear on what type of tube it is. Because think about what we just talked about with dumping syndrome. What would you be at risk for with a jejunostomy tube?
Maybe not digesting anything.
Well, you're going to be at risk for dumping syndrome because now we are bypassing the stomach. We're going right into the intestine. So we're worried that things are going to go through too quickly and you're going to end up with that dumping syndrome. So anyone with a jejunostomy tube that gets tube feeds, we always automatically would want to put them on a pump. We probably wouldn't give them, bolus feedings from there. Make sense? Okay. Any specific questions about anything we just talked about? Okay, I will put a new discussion post up for you guys, hopefully in a little bit here. So you guys go ahead and do that. Hopefully you don't mind these discussion posts. I think it's kind of helpful since we can't talk as much as we normally would have in class. I try to make it on something that's going to be, helpful to you to know. So we'll see. I'm not quite sure what I'm putting on there yet, but I'll figure it out. Anyway, make sure you guys go to your Canvas and go into conferences to see if we can get into this practice test that she was talking about, and hopefully we can get this stuff figured out for testing. I will get you guys, I'll keep you guys updated as much as I can about this. So just, I get it. I'm just as frustrated as you are about this testing because I wanted to get this testing done this week because we're already behind a week. So let's see if we can test this out and hopefully we can get the ball rolling and get things done quicker that way. So get in there and see if you can do that. And then if you have any issues or you don't see it or something like that, just chat with me and let me know so that I can see what's going on and I can contact this lady about it. And then just watch your email for other updates as far as like your clinical stuff that we talked about. And we'll go from there. Questions?
What time is like the assignments due? By midnight on the due date or?
Yeah, I'm just making everything by midnight just to make it simpler for everyone.
Okay.
And everyone just send me stuff through email. I prefer to not get pictures of anything, so because it's too hard to like print it out and see everything real good in a picture. So try and do it not as a picture. Okay, everyone, thanks for coming back in here. If you have any problems or questions, please let me know. We will meet again on Thursday, so I'll send you out another invite for that.
All right, thank you.
All right.